So this is part of Foundations of Critical Care. These are some of the things that aren't as hard of concepts that we can talk about here in this PowerPoint versus in a class discussion. So critical thinking, what comes to mind when you see the following terms such as intensive care, critical care, ICU and CCU, trauma, and intensivist? So the critical care environment deals with human responses to life-threatening health problems. You have to remember when you have patients and families that are in the ICU, these patients are very sick, and this could be something that is a chronic issue for them, or something that is acute and very sudden that could be life-changing for a family. Characteristics of critical care nurses. They need to have the ability to think critically and quickly, well organized, knowledgeable about disease processes, develop relationships with patients and families, and work closely with the interprofessional team. Now, if you are a critical care nurse, the more that you are in critical care, you start seeing some of the same disease processes, such as if you are in MICU, you might see a lot of sepsis or pneumonia or MIs, drug overdoses, seizures, DKA. You'll get familiar with those disease processes and how to care for those particular patients. You do every once in a while have then patients that you are not familiar with, but that's why resources are available to get you familiar with how to care for those patients. And while working in the ICU, you will develop a relationship with patients and families. You're with the patient 12 hours a day. And if you work several in a row, like 3 or 4 in a row, it's possible that you're going to have that same patient for all 4 days. So it's a lot of time that you're spending with that patient and family. And so you want to develop a rapport with them, explain things, explain what you're doing, how are you helping the patient, what the goal of treatment is, and what our next step is to get the patient healthier and out of the ICU. You're also going to work closely with the interprofessional team. Usually ICUs have rounds on a daily basis that consists of the physician, dietitian, pharmacy, PTOT, RT, the nurse, and social work. And with that, you talk about the plan of care, discharge instructions, a discharge plan, any new medications that need to be started, what has the patient been doing, what are our concerns, and what is our next step in the treatment course. In the ICU, we also want to focus on quality and safety. Errors must be prevented. Nurses are challenged to reduce errors and promote a safe environment. And several initiatives have been started by the Joint Commission, Institute for Healthcare, and CUSIN. The National Patient Safety Goals through JCO, some examples that are relative to nursing care, communication, medication safety, reduction of infections, and reconcile medications. Harms targeted for reduction. We want to prevent adverse drug events. That's why it's so important not to do workarounds when you're giving medications, and that when you are giving medications, you are doing solely that. You're not trying to multitask. You are only giving medications, making sure that they are correct for the patient, the correct dose, and the correct route. And you're using your computer and scanning the patient's armband and asking them their date of birth. You also want to prevent infections from CODIs and CLABSIs. Those are very large initiatives in the ICU. Usually a catheter is not placed in a patient unless it's absolutely necessary, and then it is also taken out as soon as possible. CLABSIs are something that are also tracked throughout the ICUs, and central lines are looked at on a daily basis and evaluated for their use. Why does the patient have one? What are we using it for? Can it be taken out? They also look at surgical site infections and ventilator-associated pneumonia. We also want to prevent injury from falls and immobility, pressure ulcers, and VTEs. Communication is important for safe care. There are standardized approaches that JCAHO has implemented, such as SBAR, Situation Background Assessment Recommendation. This should be used anytime there is a patient handoff, whether that is shift change, you're giving report to another unit, and transferring a patient. If the patient's coming from OR or anything like that, you want to make sure and use SBAR format. Collaboration. You want to create a culture of safety where everyone works together. You have mutual respect and mutual recognition. The aim during professional daily rounds is for collaboration between all team members, and briefings are another approach to make sure that everybody is on the same page. Now we're going to switch over to some physiological alterations, some stress responses. They can also affect staff, and so that's important to recognize what your own stressors are and how you are feeling about the patients in that day to help with your stress level as well. The ICU is a stressful place. It can be overwhelming and time consuming mentally, so you just want to take that into account for your patients and families and for yourself. Stressors for the client: presence of invasive lines, loss of control, sleep deprivation, alterations in circadian rhythms, sensory deprivation, and sensory overload. Stressors for families: lights and noises, many interruptions, no privacy, lack of sleep, information overload. It's so important that when you're talking with families that you continually explain things to them in as simple of terms as possible. These patients and their families, very stressful time. The patient's usually very sick, and they are having trouble remembering things and keeping things straight. So you want to make sure and give them as much information as possible and keep it as simple as possible. And you may have to tell them the same thing over and over again, and that's going to be completely normal. Visitation is still among the most contentious and widely researched issue in nursing. 44% of critical care units still have rigid visiting hours. 45% of critical care units have open hours, except for during rounds or shift change. I do remember when I first started as a nurse, we had very rigid ICU visiting hours. Definitely no visiting hours during shift change. Then family members could come and visit from about, I think it was like 8:30 to 10. And then at 10 o'clock we did rounds, which was closed, so family could not be there for rounds because we thought of it as a HIPAA violation. And then visiting hours would open again from noon to 1:30, and then from like 1:30 to I think 3 or 4 they were open, and then from like 4 to 8 it was closed again. I mean, it was very, very rigid, and we stuck to those hours. Nobody could stay the night. Visiting hours were over at 10 and everybody had to leave. It's just very hard, and families just didn't understand why they couldn't be there with their family member. And so a few years later we went to open hours, and you could have 2 people in the room at all times. Only one person can stay the night though, just because those ICU rooms are not very large, so when you get a bunch of people in there and trying to maneuver around the bed and take care of the patient, it's just not possible. But families really seem to like having visiting hours, and they also like to be present during rounds, and the physicians actually found the benefit of having families at the bedside during rounds, because the physician can answer all their questions, they can answer the patient's questions, talk about the plan of care, and that way families weren't trying to hunt down the physicians, the nurses weren't trying to call physicians with questions from the family. It was all just done right there. So take a look at this picture and just think about how you would feel if this were your family member. If we look at the picture, there's about 6 or 7 IV pumps there. They're on some kind of advanced hemodynamic monitoring, a balloon pump, dialysis, they're on a ventilator, just a lot of things going on. So just imagine if you were a family member walking into a room and how overwhelming this would be, and can I even touch my family member? Can they hear me? And just lots of questions. And so just be mindful of that and just explain things as best you can to the family and in as simple terms as possible. Don't forget about family needs for your patients in the ICU. Receiving assurance. Don't ever give false hope, but assure them that we're doing everything that we can. This is what we're looking at. This is what we're hoping that this, if it's a medication, that this will do. They might feel like they need to remain near the patient, which is fine, but just, remind them, hey, I might, need to get in here and do some things, and you might have to step out. And families are usually very compliant with that as long as you keep them in the loop and keep them knowing about what's going on. Receiving information, being comfortable, I always offer to give them a warm blanket, things like that, some towels for a shower, if there's one available to them, so they can also, be clean and feel refreshed as well. Make sure they have available support as well. If there's anybody we need to call, is there a chaplain that can come and sit with the patient, or sit with the family member to be with them for a while. So we're going to switch over to some nutrition things that you might find in the ICU. All critically ill patients are assumed to be at nutritional risk, and a nutritional support is an important part of overall care plan. When patients come into the ICU, they're sick, their metabolic needs are usually increased. They might not have been eating well before they came into the hospital, and so we want to make sure that we get their nutritional diet restored and started to help increase and speed up their recovery period. So nutritional assessment provides subjective and objective data regarding nutritional status, determines nutritional risk factors, identifies nutritional deficits, establishes nutritional needs, and identifies medical, psychosocial, and socioeconomic factors. Usually the dietitian is responsible for coming around and doing a nutritional assessment on the patient. But the physician can go ahead and start some nutritional things on the patient, if it's in the middle of the night, or we know that the patient might be intubated for a long period of time. We can go ahead and start some new orders and go from there, and always alter them as needed. Nutritional therapy goal is nutritional support consistent with metabolic needs and disease process while avoiding complications. Any patient who cannot meet the needs orally for 3 or more days requires nutritional support. So any patient that might be intubated for a few days, we'll go ahead and start enteral feedings on those patients. And you want to always, be consistent with their metabolic needs and disease processes. If it's a patient who is a known diabetic, comes in, they're not going to get the same enteral feeding as somebody who's not a diabetic. They're going to have a little bit different a makeup of the enteral feeding. So that's important to know when you're starting certain feedings. Why are we giving this particular one? What does it have in it? Usually it has to do with the amount of calories, the amount of sugar that are in certain bottles and in a certain amount of the enteral feeding. Nutrition care plan, determine the patient's calories, protein and fluid needs, intake targets, the route of administration, set measurable short and long-term goals. Some of those examples would be like weight gain, stable laboratory values. Enteral nutrition, delivery of nutrients to the GI tract. It's the preferred method, lower risk of infection, less expensive. Small versus large bore tubes for delivery. Usually we start out with a large bore tube, like an NG or an OG tube. You can give tube feed through that. It's just nothing that's long term. It's usually not very comfortable for the patient, and it just doesn't work as well. It tends to get clogged, things like that. Small bore are much more comfortable for the patient. They're usually much easier to place, and the patient usually tolerates it better. Most of the OG or NG tubes are going to be gastric. When we use a small bore feeding tube like a Dobhoff or Corpac, we're going to use, it's going to be what we call post-pyloric, past the stomach, and so we're going to feed right into the small bowel. And long-term nutrition could be a PEG tube or a jejunostomy. Guidelines for enteral feeding, short term, like I talked about, the NG tube, the OG tube. Long term is going to be a gastrostomy or jejunostomy. Feeding schedule, you can either do intermittent or continuous. Usually when we first start tube feedings, it's going to be continuous, just a small amount, just to feed the gut so it doesn't die. And then as the patient, starts healing, we're going to give them and increase that rate. Usually we start with intermittent if they have a PEG tube that's placed, and they're going to be going maybe to a facility with that PEG tube, unable to eat. We're going to start them on intermittent feedings. Assessing gastric residuals. You can only assess a residual on a gastric tube, a tube that's in the stomach, like an NG or an OG. If it's anything that's post-pyloric, like a Dobhoff or a Corpac should be, you cannot assess a residual, and you can't assess a residual in the small bore tubes because it's just impossible. You just can't pull back because the tube isn't made that way. And also, if you're post-pyloric, you shouldn't have any residuals because it's going right into the intestine. And if it is in the gastric and you have a residual, and what a residual is when you are feeding somebody enteral feedings, and like every 6 hours you put a TUMI syringe on the end and pull back and see if you get any tube feed back. And sometimes people have large residuals. They're not emptying their stomach for some reason. Things just aren't moving through. And so you have to determine, why is that happening? Do they have a small bowel obstruction? Are they just not, their gut just not moving enough? Do we need to help, give them some medications to help with that, and go from there. Now, parenteral nutrition, used for patients who are unable to tolerate enteral feeding, such as GI obstruction, intractable vomiting, intractable diarrhea, NPO for an extended period of time, greater than 1 week. Patients who are admitted very malnourished, you want to start immediately, and if unable to tolerate enteral feedings, or they're unable to meet the nutritional demands with enteral nutrition. Parenteral nutrition is very expensive. It carries a high rate of infection risk because it's got a lot of sugar in it. And with that sugar, the bacteria just loves it, just feeds off of it. So you are more likely to have an infection in the line. And also with parenteral nutrition, it has to be run through a central line. It cannot be run through a peripheral line ever. Complications of parenteral nutrition: infection, electrolyte imbalances, fluid imbalances, hyperglycemia. Patients get hyperglycemic from tube feed or from TPN due to the amount of sugar that's in TPN. So you want to check their blood sugar about every 6 hours, and the physician will set parameters for that. If they do have a high blood sugar, the dietitian can order insulin to be put into the TPN bag, so it'll help balance that out. Also with parenteral nutrition, it's the bag that it comes in is good for 24 hours and 24 hours only. Bags are usually changed at 6 p.m. every day. They need new tubing, new filter, new bags, everything. And it's a 2-nurse checkoff due to the electrolytes, and make sure that it is correct for what is ordered, is the correct bag. And it's made daily in the pharmacy, patient specific. So that's important to know too. Nursing care, you want to assess the patient's ability to obtain or use nutrients. If infection, look for malnutrition as the cause. Be alert for food, nutrient, drug interactions. Assess for recent changes in health status. Weigh daily. Assess protein, energy, malnutrition in the elderly. Interpret laboratory findings cautiously. We're going to switch gears and talk about end-of-life decisions and support for families. Helping families make decisions about life support. You want to communicate frequently and honestly. You want to engage in consistent communication as well. Make sure everyone is on the same page on the healthcare team. Base decisions on the patient's wishes and provide psychological support for the family. Some ethical issues in the ICU that you might come across that could consult an ethics committee. Disagreements or conflicts that exist on whether to pursue aggressive life-sustaining treatment, such as CPR, or emphasize comfort palliative care. Family demands to provide life-sustaining treatment, such as mechanical ventilation or tube feeding. Competing family members are present and want to make critical decisions on behalf of the patient versus family members who are not present, who do not want maybe aggressive care, or who want aggressive care. It just kind of depends. That's one of the most common ones that we find. Along with a seriously ill patient, is incapacitated, does not have a surrogate decision maker or an advance directive. We also find that to be an ethics committee review. Death in the critical care, preceded by withholding or withdrawing aggressive support. 95% of decisions are made by surrogates, often not based on the medical prognosis. Outcomes of decisions often not understood. Nurses' role to explain the choices to patients and family. Some common beliefs in the ICU. Patients die of distinct illnesses that are potentially curable. Dying is often viewed as a failure on the part of the system or providers. The purpose of the healthcare system in the United States is to treat disease, illness, and injury, which we're trying to move towards more of a population prevention health, to where we're going to try to prevent some of these things from happening, prevent people from coming to the hospital because they're going to be healthier, they're going to be more compliant with their medications, and different things like that. The effects of end-of-life issues on nurses and healthcare teams, ethical conflicts, moral distress, concern for the patient's dignity, how to maintain a professional distance. You want to be there for the family, help support them, be there if they need anything, but you don't want to get too far into family drama, things like that. You need to stay a professional distance away. But also they'll be supportive of the family and what their decision is. Advanced directives. CPR, should a patient be coded? And that's a question that's asked a lot. A do not resuscitate order is needed to not initiate a code. Everyone that comes into the hospital is a full code unless otherwise noted. Advanced directives are useful in guiding decision making prior to a code, so I encourage everybody to talk to their families about advanced directives and make sure that they have them drawn up, and so there's no question when it comes to that time. Family presence during codes is promoted. There's a big push to allow family members to stay in the rooms while the family is being coded, and they actually find that family members want to be in the room. They like seeing how hard everybody's working to help save their loved one. It's not true that they're more likely to sue. It's actually the opposite. and they want to be there with their family member in case they do pass away. Advanced directives describes a patient's preference for treatment in terminal or vegetative states. It's legally recognized. Presence of advanced directive and end-of-life care desires should be shared with significant others long before they are needed. Common symptoms at end of life: pain, anxiety, hunger, thirst, nausea, diarrhea, confusion, agitation, just to name a few. Nursing interventions for palliative care: frequent repositioning, good hygiene, skin care, creation of a peaceful environment, and pain relief. Withdrawing or withholding treatment. The withdrawal of treatment is discontinuation of life-sustaining therapies in a terminally ill or persistently vegetative patient. Withholding of treatment, failure to initiate life-sustaining therapies in a terminally ill or persistently vegetative state. So those two things are very similar, but they are different. Withdrawal, we are going to discontinue something that's already started, and withholding, we're just not going to do something that we might normally do if the person was going to survive. Ventilator withdrawal, the most common withdrawal intervention. It's called terminal weaning. Titrate pain medications and sedation during this process. Relieves tachypnea, dyspnea, and use of accessory muscles. Ethical principles: death is a product of their underlying disease. Goal is to relieve suffering, not hasten death. Withholding life-sustaining treatment is moral equivalent of withdrawing treatment. Any treatment may be withheld or withdrawn with patient and family consent. Ethical principles: any dose of analgesic or anxiolytic medication may be reasonably used to control pain and relieve suffering. Most facilities have protocols for palliative care or an order set that the physician fills out. So you can give whatever's on that protocol. If something's not working on the protocol, you need to let the physician know so something can be changed. Life-sustaining treatment should not be withdrawn from patients on paralytic agents. That's because you're inhibiting them from moving, so you need to wait for that to wear off before you can progress to any withdrawal of care. Cultural and religious perspectives may affect patient and family decision making, so make sure you take that into account when you are withdrawing care on a patient. Some commonly withheld therapies: vasopressors, antibiotics, blood and blood products, nutritional support, and possible deactivation of implanted devices. Nursing interventions: provide anticipatory guidance to patient and family, anticipate distressing symptoms and medicate to relieve symptoms, titrate therapy to relieve emotional and physical distress. Make sure you let family know how this process is going to go. That way there's no surprises, and they're aware of things as they're happening. They're gonna ease into that transition much better than if you don't tell them anything and their family member is gasping for air and they're scared because their family member is scared or seems uncomfortable. You want to give them step by step of how this is going to happen, what we're going to do, what medications we're going to give to make this process a smooth transition. Hospice emphasizes comfort rather than cure. It views dying as a normal process. It's more of a philosophy of care. It's not a location. So you can be essentially anywhere and be on hospice. You don't have to just be in the hospital or just at a hospice facility to be on hospice. It's more common in oncology, appropriate when aggressive interventions are withdrawn, and quality end-of-life care.